Hello, my name is Martin Fielder. I'm an OBGYN in private practice, and I'm here today to talk to you about early pregnancy complications. First of all, as an overview, pregnancy is an exciting time for a woman, but it's also very nerve-wracking as well. Our goal as caregivers is to reassure our patients for the normal issues that typically occur, but to be alert to the potential complications and issues that can arise. A couple of main thoughts in evaluating a patient in early pregnancy. You may be well informed, but the patient likely isn't. And the second thing to know is to always validate the patient's concerns. Often they are scared and they need you to know that. All right. As we talk today, we're going to talk about the potential complications in early pregnancy. Mainly we're going to focus on four main topics: ectopic pregnancy, abortion or miscarriage, incompetent cervix, and recurrent pregnancy loss. We'll go over those. Ectopic pregnancy. Now, by definition, ectopic pregnancy is a pregnancy implanted anywhere except the normal intrauterine endometrial cavity. Most occur in the fallopian tube, and that's probably over 90% of the time. Other locations can include the ovary, other uterine locations including the cervix and in the cornua, or abdominal implantations. Incidence, about 1 to 2% of all pregnancies are ectopic. Now the main place, if you look at a diagram of the uterus, you'll see that they are tubal. Now in the tube of course can be divided into several different portions. The ampullary portion is probably the most common place that we'll see an ectopic pregnancy occur, and that's about 80% of the time. That's typically where the sperm meet the egg and fertilization takes place, and so usually right then and there is where the ectopic pregnancy will start to develop. Fimbrial, not that common, about 6% of the time. The isthmic portion of the fallopian tube is about 12% of the time. The cornua has about 2%, and the cervix is less than 1% of the time that we see an ectopic pregnancy. Risk factors. Anything that can interrupt the path of a fertilized ovum from reaching the endometrium will elevate your risk for ectopic pregnancy. However, most ectopic pregnancies do not have an identified risk factor. History of STDs or PID, probably the most common risk factor that you'll see, and that's because it damages the tube, especially the cilia that line the tube that move the fertilized embryo down the fallopian tube. Having a previous ectopic pregnancy, of course, will elevate your risk. Previous tubal surgery, i.e. a tubal ligation. Prior pelvic or abdominal surgery, anything that will cause adhesions and that can cause a tubal defect. Endometriosis, probably more of a severe variety that's causing scarring. Current use of progesterone or estrogen, probably progesterone actually is the more important one of that, because that can decrease your tubal motility. IVF and other assisted reproduction. IVF stands for in vitro fertilization. That's because we are purposely implanting eggs or embryos into the uterus, and oftentimes that'll disrupt its normal path. Patients that have congenital abnormalities within the uterus, for example, if they were exposed to DES, which is a medicine not used anymore, but there are still some patients whose mothers took DES during their pregnancy, caused them to have an abnormality of their uterus. And the use of an IUD for birth control. Now, having an IUD does not increase your overall chances of developing an ectopic pregnancy. IUDs prevent pregnancy. However, if you get pregnant while having an IUD in place, then you have a risk factor for an ectopic pregnancy. The IUD is disrupting the normal endometrial lining. The fallopian tubes, however, are not affected by the IUD. So if a pregnancy does occur, it is more likely to be an ectopic pregnancy than to be in the normal location. So signs and symptoms of an ectopic pregnancy. Abdominal or pelvic pain, that's probably one of the #1 presentations. Vaginal bleeding, although it's usually very light. Pregnancy symptoms, they're still pregnant, they still have circulating pregnancy hormones, so they'll have nausea, breast tenderness, fatigue. And then the key that you have to remember is that symptoms sometimes may be absent, and so you have to have a high index of clinical suspicion. So, clinical diagnosis, you have an abnormal rise in HCG levels, but that only happens sometimes. Typically the HCG levels should double or at least go up 60% every 48 hours. With an ectopic pregnancy, frequently it will not do that. However, in early stages it can. Abnormal ultrasound findings. Usually you will see an absence of intrauterine sac and the possibility of an adnexal mass or free fluid on the ultrasound. However, sometimes that won't be present. So in general, the most classic diagnosis or diagnostic criteria that you'll see is that you'll have an HCG level of about 1500 or greater, but you won't see an intrauterine sac on a ultrasound of the pelvis, especially a transvaginal ultrasound. Your classic presentation is going to be a patient who presents 6 weeks from their last menstrual period with new onset unilateral abdominal pain with some slight vaginal bleeding. They will be tender on one side more than the other on your physical examination. The cervical os will be closed on speculum exam. The ultrasound will show a mildly thickened lining of the endometrium, about 5 to 10 millimeters, without an intrauterine sac, possibly seeing an adnexal mass with some free fluid. The hemoglobin and hematocrit will be low normal, and your HCG levels will be 1500 to 4000. That's sort of your classic presentation. So when we're managing a patient who presents with a potential ectopic pregnancy, you see them, you evaluate them, you get a CBC, you get an HCG level. If the symptoms aren't exactly obvious, you'll follow that HCG level. You'll see if it's rising appropriately or inappropriately. You'll see when it hits the discriminatory zone. That's when the HCG level hits about 1500. You should be able to see something on intrauterine ultrasound. If the presentation appears where the patient has what we call peritoneal signs, basically severe abdominal pain, then you have to err on the side of assuming this is ectopic pregnancy, because if untreated, it can be lethal. Treatment. The unstable patient, as we mentioned before, immediate surgery is indicated. You'll have to decide at that time if you're going to do a laparoscopy, which is where you make small incisions in the abdomen and use a camera and instruments, or if you do a laparotomy, where you make an open incision. If you have a stable patient, then your decision tree adds in use of medication such as methotrexate. So typically in that situation, we'll either do laparoscopy, which is an outpatient procedure, or we'll use methotrexate, which is a chemotherapeutic medication that kills rapidly dividing tissue, which a pregnancy is. There's no role for observation alone. However, if a patient does have an ectopic pregnancy, about 50% of the time they will resolve on their own. But that's an unacceptable rate to use as a routine management tool. So the gold standard is laparoscopy. When you do laparoscopy and you look inside with your camera and you have your instruments there, one of the main decisions you have to decide is whether or not you're going to remove the fallopian tube or not. And there's two different schools of thought on that. Some believe since the tube is damaged, you should remove the tube. That guarantees that you're moving the abnormal tissue. The other school of thought is that if you just open the tube up, remove the abnormal pregnancy, the tube will heal on its own and potentially will still have function. The studies don't clearly establish one preferred method over the other, so either is available to you. However, if the tube is ruptured, it's been well described that it's not preferable to remove the abnormal pregnancy and try to repair the tube. In that situation, you just should remove the tube. If you do not remove the tube, you should follow the HCG levels down to 0 to ensure that there's not any remaining ectopic pregnancy tissue left inside the fallopian tube. Laparoscopy is preferred over laparotomy if the clinical situation sets itself up for that, because it does reduce the recovery time and complications. And then we always do proceed to surgery anytime there's a question that the patient cannot be compliant with her methotrexate regimen. Methotrexate requirements. Patient needs to be hemodynamically stable. They need to be reliably compliant with the post-treatment monitoring. They need to not have any active renal or liver disease, because that's how the medicine is processed. Relative contraindications is if the HCG level is greater than 5,000, or if the size of the ectopic is greater than 3 centimeters and there's no fetal cardiac activity on ultrasound. I say relative because we used to make those contraindications, but we found later that we still can use methotrexate in some of those situations. There's several different regimens of administering methotrexate. The most commonly one used is a 50 milligrams per meter squared, that's body surface area, in an intramuscular injection. You'll follow serial HCG levels. You'll check them at day 1, the day of treatment, day 4, and then day 7. What you're looking for is a 15% or greater drop from day 4 to day 7. That shows that we're getting effective cell kill by use of the methotrexate. Then we'll do weekly values thereafter, expecting to see a 15% or more drop each week. You can retreat if the levels plateau or if they rise. Most people will consider a laparoscopy or laparotomy if our levels do not fall after the second dose. One thing that's unique to using the methotrexate is that we don't want them to have folic acid. That's how methotrexate works. So we'll ask them to stop taking their prenatal vitamin, which has folic acid in it, and we'll also ask them not to have a large intake of green leafy vegetables or anything else that will be high in folic acid. Now, a special case of ectopic pregnancy is called a heterotopic pregnancy, and that's when you have basically one in and one out. One where it's supposed to be and one where it's not supposed to be, a twin pregnancy. It's a rare event. It's estimated at 1 in 30,000 pregnancies. However, it may be as high as 1% in pregnancies that are conceived by assisted reproductive techniques, such as IVF or intrauterine inseminations. The management is typically surgical, although they have shown in specific instances you could inject potassium chloride directly into the ectopic pregnancy, thus trying to save the pregnancy that's in the normal location. All right, now we'll talk about spontaneous abortion. Now, for our discussion, the medical term is abortion. However, most of the time you think of that as miscarriage. So I'll probably use the words a little bit interchangeably during our talk here. A complete abortion is when we have complete expulsion of all products at conception before 20 weeks of gestation. An incomplete abortion is a partial expulsion of some, but not all, of the products at conception before 20 weeks. An inevitable abortion is that's when you have no expulsion of the products at conception, but you have vaginal bleeding and dilation of the cervix such that a viable pregnancy is unlikely. A threatened abortion is anytime you have any vaginal bleeding before 20 weeks, with or without dilation of the cervix or expulsion of products at conception. And then there's a missed abortion, and that's when you have death of the embryo or fetus before 20 weeks with complete retention of all products at conception, no bleeding, no dilation, no passage of tissue. So you got that? A bunch of different definitions there, and I'm sure you'll see those again. All right, spontaneous abortion or spontaneous miscarriage. About 15 to 25% of all recognized pregnancies, pee on the stick and it shows positive, end up in miscarriage. Over 80% of those occur in the first trimester. Now, if you actually did pregnancy tests, blood pregnancy tests on women every single day, it's probably more like 50% of all conceptions end up in miscarriage. It's just many of those are not recognized. Most all miscarriages occur due to developmental abnormalities or abnormal chromosomes or disorders of implantation. So that means that the baby was either developing genetically abnormal, had an abnormal chromosome count, or that it just didn't grow. My analogy for that is if you take some seeds and you throw them in the ground, some of them will grow into plants and some of them won't for whatever reason. And that's the same that'll happen with fertilizations. Now, less common reasons for miscarriages are going to be anatomical defects of the uterus, infection, endocrine factors such as uncontrolled diabetes or thyroid disease, or immunological issues where the body rejects the fertilized embryo. First trimester abortions. Symptoms: vaginal bleeding, and that's the #1 symptom, oftentimes heavy, cramping, and then you'll also see a loss of pregnancy symptoms. Patients will notice that they have less nausea, less breast tenderness, and less fatigue. A diagnosis. As we mentioned before, with a normal pregnancy, your HCG levels should double or at least have a 60% rise every 48 hours. In a miscarriage, these will not occur. Ultrasound.